Yes. Welcome to the fifth session of ALCAP. The ALCAP webinar series were started by Asian Pacific Association for Study of the Liver to increase knowledge base, algorithmic approach, and improve patient outcomes across the world. ALCAP program has a very strong advisory board and also a very strong panel of experts. In the last 4 sessions, several topics including resection, transplant, and surgery has been considered. Today, on behalf of our president, Professor Sheena, who could not join due to some emergency issue, I would like to welcome all of you across the world for this very important 5th session, which is liver-directed loco-regional therapies for advanced HCC. We have an outstanding specialist, one of the respected Professor Kanda, experts from Japan. Thank you and welcome, Professor Kanda. We also have a series of very good experts, Professor Baijal, Dr. Deepti Sharma, and Professor Shalini Thapar. We have many experts across Asia who have joined, and I would also like to thank Dr. Ashok Chaudhary, who is the program coordinator for this to having organized. With this, I would pass on to Professor Kanda, the moderator, for taking over and introducing the speakers for these sessions. Thank you.
Thank you, Professor Sarin, for your kind introduction. This is Tatsuo Kanda from Japan. I will introduce today's speakers. First speaker is Dr. Sajan Sarin Bajar, interventional radiologist, chairman, fellowship, MD, MBBS, Gurugram, India, works at Mendas, Mediti, Garand, 35 years of experience. I will introduce introduction of Dr. Bajar. He is an eminent radiologist with experience of 35 years. His area of expertise covers vascular and interventional radiology and gastrointestinal radiology. He also offers treatment for pediatric cardiology. His special interest, radiodiagnosis, vascular radiology, gastrointestinal radiology, interventional radiology, embolization, etc. And he also special interested in radiofrequency ablation. Professor Bajar, let's talk, please.
Good evening. I must thank APASL for giving me this chance to interact with this elite audience across the Asia-Pacific region. It is a pleasure to talk to you and share some of my experience and thoughts on the management of advanced liver cancer, which is the topic assigned to me. May I share my screen now?
Yes, please, sir.
Yes.
Is it visible?
we can see your slide.
Thank you. So the topic assigned today is what is the various transarterial methods of treating patients and how to select, if possible, there is an optimized way to triage them in different treatment protocols, and what would then be the outcomes if we were to do so. So to briefly go back, these are my disclosures. To go back to the new BCLC, which is not so new anymore, it has given us the now flexibility of placing patients in different algorithms, but allowing for stage migration and hence moving from one treatment to the next. So therefore, today we've got to discuss patients who are in advanced stage of HCC, be it because of portal vein invasion or extrahepatic spread, or even patients who have had a deterioration in their performance status and have therefore been upgraded from an earlier stage basis tumor burden to an advanced stage because of the poor performance score. So both of these would come into the advanced HCC group, which is therefore summarized in this slide, which tells us about the patients having some disability with regarding their performance status and, of course, portal vein invasion. The portal vein invasion for optimization of comparison of results is best done using either of these methodologies of labeling from VP1, which would be a segmental involvement, to VP4, which would be the main portal vein and extending to the splenic and even the superior mesenteric veins. We understand that systemic chemotherapy is a very exciting strategy now, which has come to the fore and has replaced previous methods of systemic medication with the newer immunotherapy drugs proving to be far more effective than what was originally always talked of and was sorafenib. And there are further lines of therapy that are also being considered. And hence, if you look at the BCLC recommendation, there is a fleeting mention of TARE, which is also known as SIRT. And it has been suggested that it could be as effective in liver-only disease if you were to use that versus sorafenib. And the reason for that is because they said until more positive trials are available, the only one they can make recommendations on is the SARA trial. And here, even though it was a failed trial, we must understand and spend a minute as to why it was a failed trial. And unfortunately, there was too much heterogeneity. The structure of the trial was not so optimized, and hence if you do a subgroup analysis going backwards, even though the overall survival was just 9 months, if the Y90 was done with adequate dose delivered to the tumor, one sees that the significant longer survival can be attained of 14 months versus if it is less than 100 gray and you would land up with a dismal outcome of just 6 months. It's also seen that if the planning of Y90 was replicated on the therapy of Y90, then certainly the outcomes would be far better as compared to if there were discordance, which unfortunately was there in a large number of those patients. Another interesting algorithm that came out about 2 years ago from Japan was how to manage patients with portal vein tumor thrombus. And in spite of the thrombus invading up to second order branches, the push towards liver resection and going to salvage with transplantation was pushed to the fore. And treatments of locoregional nature using TACE, SBRT or TARE were emphasized upon, and hepatic artery chemoinfusion as well, all being pushed towards downsizing, downstaging, trying to get these patients to ablation and transplant, which effectively is now what the mindset of most of us as we go deeper into management of advanced liver cancer. This 2021 publication that came from Japan talked in great detail about the three most standard forms of treatment that are used in loco-regional therapy. The first one they talked about was the hepatic artery infusion chemotherapy with an evidence level of 1B and a recommendation of B for patients who had PVTT extending from type 1 to type 4, but with preserved liver functions. They said HAIC using oxaliplatin or 5-FU would be the most appropriate treatment if HAIC were to be used. As far as TACE, again, with patients with preserved liver function, Child-Pugh A, if the tumor was invading the portal vein tumor thrombus up to the segmental and up to the sectoral levels, with a high level of recommendation and evidence, one could suggest TACE. Because of the presence of some RCTs in which combinations of TACE with radiotherapy were used as compared to TACE alone, there is a recommendation that combination would definitely help. And similarly, molecular targeted therapies along with TACE seem to be better than TACE alone. There was a negative recommendation or a suggestion with a slightly lower level of evidence and support, in which it was said that patients with a more compromised liver function or a more advanced portal vein tumor thrombus, type 3 or type 4, are best not treated with TACE. With Y90, again, it was 2B level of evidence with a recommendation of C that patients with Child-Pugh A and portal vein tumor thrombus up to type 3 could be patients who would benefit if SIRT or TARE were to be used. And hence we look at this in APASL modified BCLC staging system, which is, I think, just about to be published, in which the advanced stage was therefore broken up into two subgroups, in which there are patients who have extrahepatic disease who go straight to systemic therapy. But in patients who still have liver-centered and just locally advanced disease in the form of PVTT, one should be more aggressive locally and try to achieve tumor control / downstaging for further treatments. And I'll come to that in a little while. If we look at a study which compared safety of sorafenib versus HAIC in patients with advanced HCC, it was very interesting to see that the median overall survival and the TTP were significantly longer if we were to use targeted therapies, because the disease logically is still contained within the liver, even though it is locally advanced in the PVTT, as compared to if one were to go to sorafenib alone with a 14.9 month versus a 7.2 months in the overall survival. And therefore, the objective responses were also therefore more in the loco-regional therapies. If we look at this RCT that compared sorafenib plus low-dose cisplatin 5-FU HAIC versus sorafenib alone, coming from this study from Dr. Kudo and Dr. Arai, of RCT which said that if you were to use HAIC along with sorafenib, patients would do better rather than using sorafenib alone. But interestingly, when they broke up the groups, there was no significant difference if this combination was used in patients who had no vascular invasion or even vascular invasion up to VP1 and 2-3. However, it was in VP4, that means the most advanced local HCC patients, where the benefit was coming through. And it is in those patients that we would definitely have an extra overall survival, rather than if sorafenib was used alone. And therefore, if we look at a more detailed chart which shows how the outcomes of VP3, VP4, we look at the distinct differences in the outcomes. Similarly, if we look at VP3, VP4, again, significant months of difference. And in the study of Dr. Kudo, which I just mentioned, a distinct difference. And similarly, again, VP4 showing a 9.7 versus a 5.5 month difference. And therefore, the overall survival, trying to say, is the advantage is the best if the disease is also the most advanced. And therefore, could we make a summary? I think the closest that one could summarize is that HAIC with sorafenib has a role in VP4, and it has shown to be of advantage over sorafenib alone in this advanced stage of HCC. When we look at transarterial chemoembolization, and again, combination therapies of TACE with radiotherapy versus chemoembolization alone, again, in this locally advanced stage of HCC, it has been found that, interestingly, the blending of RT with TACE has resulted in patients requiring lesser number of TACE sessions, which was a very interesting outcome of this analysis that was done of a large group of studies. And they also found that there was significantly better 1-year, 2-year, and 3-year survival rates for patients in whom TACE with RT was done versus TACE alone. And this happened to be seen in patients who had PVTT or without PVTT as well. Though today's topic is ones with PVTT, therefore, this meta-analysis concluded that combination with RT makes a definite impact. An RCT, which again evaluated the role of TACE with external beam versus sorafenib alone, and an outcome at 12 weeks showed that it was distinctly superior if TACE and RT were used as far as progression-free survival was analyzed. A further analysis of these patients at 24 weeks also, it showed a much better radiological response if TACE and RT were used as compared to sorafenib. There was a superior 31 weeks versus 11 weeks advantage as far as time to tumor progression was seen, and it also reflected in an overall survival advantage if TACE and RT were used as compared to sorafenib alone of 55 versus 43. Though we do understand at this point that the standards have changed, and I must admit that it's now sorafenib has to now give way to immunotherapy, and that's what actually the proof of the pudding would be if data comes in there. If we look at a propensity score match analysis of chemoembolization plus RT versus chemoembolization plus sorafenib, again, there was not too much of a difference. Trying to say that something is added on to TACE, and that's what really improves the outcomes, and whatever you add to TACE would definitely be of benefit. So can we summarize again here? We can say that there is a role of combined therapy of TACE with RT or with sorafenib in patients with PVTT. And either of these would improve progression, time to progression, and would also impact on overall survival. We must therefore also understand that combination holds the key, because compared to TACE alone, I think combination therapies would give better results. Which brings us to the analysis of data of Y90. And I think that the legacy study is the study which has brought in the role of Y90 in the BCLC classification. And interestingly, 40% of patients in the legacy study group were those patients with advanced HCC. However, they were all there because they had a poor performance status, because one of the inclusion criteria upfront was absence of portal vein invasion. So trying to say that the other cause of patients getting into the advanced stage, that is a poor performance status, does not take them away from locoregional therapies. And therefore, in that patients, the legacy study, which showed that if you were to treat using an appropriate dose of radiation to these patients in the advanced group, one would get a good outcome. And these were the inclusion criteria, which, like I said, that there was no portal vein thrombosis and they all had preserved child score. They looked at local tumor control and they looked at duration of response. The duration of response was labeled as response after the documentation of the first response. And here in the patients with the advanced HCC, there was at 3 years a survival of 93%. Though I must again reiterate that these are advanced HCC because of a poor performance status and not because of the local portal vein tumor invasion. Here is another group which compared an RCT of patients who were undergoing Y90 versus DC beads. And here again, the patients who were in the compromised ECOG performance state were the reasons why they were being labeled as advanced HCC. And here the results were so overwhelmingly more superior in the Y90 study as compared to the DEB arm that the study was terminated because the time to tumor progression was 17 months compared to 9 months, and the overall survival was also nearly double in the Y90 group. If we look at patients who had BCLC-C and BCLC-D in this analysis of 17 studies, in which there was 1 RCT, 4 prospective studies, and 12 retrospective studies, they had patients who had portal vein tumor thrombus. They found that there was no significant overall survival difference if you were to use TARE or you were to use TACE, but the time to tumor progression was significantly superior, nearly double that if Y90 were used 17.5 months as compared to 9.8 months if TACE was used. Definitely, therefore, saying that you would require multiple sessions of TACE to achieve the same results. The reason why I bring in the dosisphere study is that this actually emphasized the appropriate use of radiation in Y90. Y90 has to be done the right way in the right group of patients to give them the best benefit. So in this group of patients who had PVTT, the effort was to try to decide what is the best dose and how does dose really impact on outcomes. So once the patients were found eligible for Y90, they were then broken up into 2 groups: the standardized dosimetry, which gave 120 gray, or the personalized dosimetry, where the effort was to give at least more than 200 gray, trying to go to 250 to 300 gray to the liver tumor and preserving liver function. There were large tumors because one can see that they were up to 10 centimeters, and a number of patients, nearly 2/3 to 3/4 in both groups, had portal vein tumor thrombus. So this is more exactly what is our discussion today. And very interestingly, it showed that the personalized dosimetry group, that means the group in which we were giving higher dosage as compared to the standard dosimetry, the results were 26 months of overall survival compared to less than a year if it were given in the standard way that TARE is done. If the dose was analyzed, tumors who received more than 205 gray of radiation, those patients had a dramatically superior overall survival of more than 26 months compared to those patients who received a lesser tumor dose, where then the outcomes were dismal with only 7 months of survival. Therefore, dose is the key. And if we look at these patients, how many patients got downstaged in the personalized dosimetry? Nearly a third, whereas we had only 4% who got downstaged in the standard way of doing TARE. And in the patients who had portal vein tumor thrombus, nearly half of them got downstaged if we were able to give them high dose, whereas no patient in the standardized dose. Again, overemphasizing that the dose has to be right, and we have to give high dose to achieve the best results. And a similar result was obtained when the resin spheres were used, and therefore maturation of a term called ablative tear. So high dose radiation in an ablative tear format is actually what is going to give us the best result. Whether you use glass or resin, patients who had PVTT up to main portal vein or right or left branches, the results would be superior if we got them to high dose. And if we look at the survival, it was 45 months compared to 18 months. Much better if we gave them higher dose of ablative SIRT versus just standard forms of SIRT. The Korean study has also very recently come out with their experience, in which they said that the overall survival of tear as compared to TKIs was significantly better, of 28.2 months as compared to just 7 months in the TKIs, with a much lower risk of death. They also said that the progression-free survival, even though similar, show in the two groups, the tear group showed definitely better progression-free survival, especially in the VP1 or VP2 patients. There was also definitely a much lesser adverse events, and therefore it was much more easily accepted. A single center study in which tear and taste were compared, even though there were a more angry and more biologically aggressive tumors in the radioembolization group as compared to the TACE group, there were more locally advanced patients in the radioembolization group as compared to the TACE group. These patients were evaluated for drug-eluting beat TACE versus SIRT, and in spite of patients having much more advanced disease in the SIRT group, the progression-free and overall survival were much better in the SIRT groups, 564 versus 271, SIRT versus DEB, and 1198 days in the SIRT group as compared to the SIRT groups, as compared to the DEB group as far as overall survival. So in both ways, TTP or overall survival, SIRT tends to score over DEB. And similar is our experience, and we wanted to actually build a strategy where we were aggressively trying to downstage patients to curative intent. In our experience that we published 2 years ago, we had a protocol of giving SIRT. We also added SBRT to the portal vein tumor thrombus. So we tried to give portal vein tumor thrombus the reason for upstaging of these patients, a double hit, trying to pull them down, to a downstaging strategy to enable them to undergo transplant. So if these patients were downstaged and then they went to transplant, we had half the patients surviving at 5 years. Trying to say that the overall survival definitely in patients who were downstage were better than if you were to put them to transplant without downstaging, which happened in a small group of patients nearly 10 years ago. The most interesting data was that patients who were downstaged, patients with PVTT who were downstage and then transplanted, if that group was compared to patients who had no PVTT and received LDLT upfront, the results were tending to come together. Trying to say that if downstaging can be done effectively, the downstaging could convert patient behavior to as if they had no PVTT. So we felt that if we could get them downstage, though the down conversion rate was not so good, but of those who reached the door to transplant, the outcomes there were at least half the patients there at 5 years. So where can we really summarize is the use of SIRT? I would say it is definitely a strongly an accepted form of locoregional therapy in BCLC-C. It has to be done in an ablative format with optimized planning and dosimetry because that holds the key to the best outcomes. Institutional experience as is built up in many centers, and now we are not the only ones. We have reports coming from other hospitals as well, where they have used similar strategies of SIRT and SBRT to the PBTT. It has proven to be beneficial as a downstaging these patients to transplantability, even though they were labeled as advanced HCC. Just to run a case and example, this was a 45-year-old male, HPV-related CLD with a relatively preserved child score, infiltrative disease, and there was a VP4 stage of the portal vein tumor invasion. It was FDG avid, though the alpha-fetoproteins were within limits. One can see that there was a portal vein tumor thrombus, which can be very obviously seen invading the main portal vein here. The patient was taken for Y90 therapy, angiographies were done, selective arteries were cannulated, and we gave 200 gray to the tumor with a lung shunt fraction of 9.5 and hence being lung safe. SBRT was given to the portal vein tumor thrombus using cyber knife after placement of fiducials. One can see the fiducials shining here. And both of these were given. There was a tumor response. The portal vein tumor thrombus was totally bland on the follow-up imaging. The tumor liver was not enhancing anymore and it was regressing. This patient was transplanted. And 7 years after transplant, the patient is still doing well. He recently came to us with follow-up and the patient is disease-free. So I'm not saying that it's a success story every time, but we aspire to try and achieve this. And I think the thrust for future studies of combination therapies probably holds the key. And if more results come out, we are waiting for exciting results of the trials of immunotherapy with SIRT versus SIRT alone for these advanced stages of HCC to pull them back into potential curative treatments. Thank you very much.
Thank you, Professor Baijar. Thank you. Nice talk about various arterial embolization approach and patient selection and outcome in advanced HCC. Is there any question from audience? No. And you stressed those is key. I agree with you. Yes. And in the India, how's the etiology of HCC and liver disease? Hepatitis B is main cause, or alcohol is called main cause?
In our patient group?
Yes, yes.
It was a mixed etiology.
Okay.
No selective tilt towards any one etiology.
Okay, thank you. And we have no experience of Y90. Do you use them for treatment HCC?
Yes. So the result that we shared was using SIR spheres, the resin spheres for our SIRT, along with SBRT to the portal vein tumor thrombus, and then if downstage successfully with a waiting period of 3 to 6 months, they would go to transplant. So we did use SIRT.
Yeah, Dr. Basil, just one of my query. So if you are having biliver disease, so what will be your plan?
So we look at the underlying liver function. If the liver function is preserved, and if we can do bilobar treatment with a lung safe dose, and we can achieve, if using glass spheres 400 gray to the tumor, or if using resin spheres more than 205 gray to the tumor, we would go ahead with bilobar treatment, with ensuring that the liver receives less than 40 gray. So the dosimetry holds the key. And we have a different dose limits if for one-time therapy versus a cumulative therapy. So if there is a dose limiting issue, we would break it up into bilobar treatment. But if we can fulfill the criteria of liver safe, lung safe, and tumor kill dosimetry, we would go to a bilobar treatment.
Yeah. So how you assess the response? It is the same CT scan, or how you assess once you have given the TAR? So how you evaluate the response?
Right. So we do a PET on the next day, or within 24 hours. It's a plain PET to document that the therapy has sat the way we had planned it. And then the response evaluation happens with usually an MRI at 2 months, then 3 months, and then 6 months. We know that there is a delayed response on imaging when Y90 is used, and hence an early evaluation is sometimes misleading, and we have moved therefore as the first imaging at not before 8 weeks.
Thank you. Professor Kanda, please.
I think, Professor Bajar, I think a little bit difficult to evaluation of the effect of the radiation therapy other than portal vein thrombus. How did you do the evaluate the response?
So we looked at the response using MR, and we had 3 criteria that we had. If it was PET avid, on the PET CT, we would have to use PET CT to show that it is non-avid. If there was an arterial enhancement on CT or MR, we had to show that it is non-enhancing on the same modality. And if there were any ancillary findings of diffusion restriction which were seen, we had to show that they were not present on the follow-up. So all the criteria had to be fulfilled to document this patient as a responder. Then only would that patient move towards a possible transplant.
Thank you. And we have several questions from audience. One question is, how about combined radiation therapy with systemic therapy in advanced HCC?
So I think that is exactly what I summarized, and I think that's what holds the key. Systemic therapy, and now with the exciting immunotherapies showing such great results, probably the ideal combination has to come. And we also firmly believe that along with locoregional therapy, it will have to be a combination with systemic therapy that would give us the best results. Though I don't have a clear-cut recommendation just now.
Thank you. Another question is, do you wait till full response before liver transplantation?
Yes. So I think we just discussed that point when you asked me to how we evaluate portal vein tumor thrombus. So that is the same answer, that we have to ensure that all the criteria which tell us that there is a viable PVTT have to be shown to have responded fully. So again, to repeat, PET avidity becomes PET non-avid. enhancement becomes non-enhancing, and any diffusion restriction on MR has to show loss of diffusion.
Thank you, Professor Bajar. Thank you for nice talk.
Thank you very much. Thank you very much. And I must thank Dr. Serene as well, especially. Thank you.
Thank you very much. We move to next speaker. Next speaker is Deputy Sharma, MD Associate Professor Radiation Oncology, ILBS, New Delhi, India. Her expertise area, stereotactic radiosurgery, SRS, and stereotactic radiotherapy, SRT for brain tumor, and stereotactic body radiotherapy, SBRT for primary liver cancer, HCC, cholangiocarcinoma, and for metastasis to liver, lung, and bone. And miscellaneous. And she also is the expert for cancer prevention, especially for SCC, GI malignancy, breast and cervical cancer, and hot dynamic therapy. Dr. Sharma, please.
Yes. Good evening, sir. So,
Yes.
Can you hear my screen?
Yes, please. I can see. I can see where. Let's start, please.
So, good evening. At the outset, I'd like to thank the team APASL for giving me an opportunity to present my data, my experience in HCC. So most of my work has been done, made easy by Professor Bajar in his previous lecture. So today's topic is radiation therapy in HCC management with or without tumor thrombosis. As we all know, as per the BCLC classification, advanced stage BCLC consists of the patient with tumor thrombosis in the form of either portal vein tumor thrombosis or inferior vena cava tumor thrombosis, with or without lymph node metastasis or distant metastasis with a performance score of 1 to 2. Such patients are usually treated with systemic therapy with the mean overall survival at 1 year to the tune of 30 to 60%. So as per the guidelines, systemic therapy is the treatment of choice. So starting from the SHARP trial to IMBRAVE trial, the overall survival is 30 to 60%, but in these group of patients, usually good liver function test patients were recruited, but the local response rate, that is overall response, complete response with partial response, is to the tune of 30 to 40%. So in this heterogeneous group of HCC with PVTT, with metastasis and low local control, there's a need of some effective loco-regional therapy so that we can increase the local control, which in turn translate into increase in overall survival as well. So the rationale for the loco-regional therapy is it reduces the burden of disease, increase local control, improve local symptoms, and has an additive effect with TKIs and immunotherapy. As per the Mu et al. In the recent publication in 23, the authors has concluded that increase in local control and early local control has resulted in increase in overall survival, even in the cases of advanced HCCs. So SBRT or stereotactic body radiation therapy is a form of radiation in which highly conformal radiation therapy to the dose of 30 to 50 gray in 3 to 5 fraction is being delivered under image guidance to achieve a tumoricidal doses at expense of minimum normal tissue irradiation. The aim is to increase the tumor control probability, but at the same time reduces the dose to the organ at risk and in turn leading to decrease in normal tissue complication probability. Now the predictors of outcomes post SBRT. So it's mainly the liver function test, tumor burden, performance status, and the sarcopenia. There are different staging has been used like CTP, LV, LBT, TNM, and Hong Kong staging system, which incorporates either of the factors like liver function test or the tumor burden. Here are the studies where LB has been compared with child-book scoring, and both the studies have showed that a baseline LB score was more discriminating than the child-book score in predicting the overall survival and toxicity in patients undergoing SBRT. Further, the LV consists of mainly albumin and bilirubin, that is the liver function test. If we incorporate the TNM staging as well, so the LVT staging, in this publication from our institution, we have showed that the patient, when subclassified on the basis of LVT score, so the patient with LVT score of 2 had a better overall survival of 100% at 1 year as compared to LVT score of 5 with a 0 survival rate at 1 year. So this shows that the LVT is a better predictor for the survival and to select the optimum treatment strategy. Further, sarcopenia is another factor which may help to find out the overall survival in long term. So in this again abstract publication from our institution and another study by Yang et al., both studies have showed that the baseline sarcopenia is associated with poor survival. Whereas the Yoon et al. Has also showed that a loss of 7% in muscle mass post-radiation therapy is a predictive factor for poor overall survival. So we have to see for the performance status as well as the general build-up of the patient as well. So keeping all this in mind, some of the criteria for selection the patient for SBRT is the patient who is not suitable for a surgery or RFA with an intact liver function of child's A to B7, LV grade 1 and 2, more than 40% of the liver uninvolved by the cancer, tumor more than 0.5 centimeter from the organ at rest, like duodenum, bowel, and oligometastatic disease is also considered as a selective criteria. Whereas the contraindication to liver SBRT is impaired liver function test with child C, LV grade 3, liver enzyme more than 6 times of upper limit normal, less than 700 cc of the non-tumor liver, and infiltration of the serial organs. Now, the role of radiation in advanced HCC can be dealt under following headings, that is HCC with PVTT, early VP1 or 2, extensive portal vein tumor thrombosis or IVC tumor thrombosis, large infiltrating HCC as a sequential therapy to locoregional therapy or systemic therapy like TKI and immunotherapy, and SBRT for the oligometastatic disease. Some uncommon scenarios are ruptured HCC and post-IVIT recurrence. So I'm not going into details as already been discussed earlier. So HCC with portal vein tumor thrombosis, VP1 and VP2. So in this, the radiation therapy can be used as a downstaging procedure, either as a single modality or as a sequential therapy with TACE or TARE, especially for VP1 and 2. So in this trial, which is published in JCO 2019, here the adjuvant radiation therapy has been used as a new adjuvant procedure. And post-radiation therapy, there was a partial response of 20% and stable disease in 70% of the patient. And we can easily see that the overall survival and disease-free survival was more in the patient who received new adjuvant radiation therapy as compared to upfront surgery. Similarly, this is another paper where sequential therapy with TARE has been used, and this paper is already discussed by Professor Bejel. And again, there are 63% of the patient were downstage post-radiation therapy and TARE procedure. And further, in 25 patient LT was done. So the 5-year overall survival in the downstage group of patient as well as 5-year disease-free survival in the downstage patients were better in as compared to the non-downstage group. Now, the role of radiation therapy in extensive portal vein tumor thrombosis. Extensive portal vein tumor thrombosis usually refer to the VP3 and VP4 or the inferior vena cava tumor thrombosis. So these are some of the studies where the radiation therapy has been used in extensive PVTT and IVC tumor thrombosis. Again, with radiation therapy, we could achieve a complete response and partial response, that is overall response rate, up to the tune of 72 at 80%, and progressive disease was there in about 10 to 15% of the patients, with an overall survival ranging from 30 to 40%. This is one of the studies which has been published from our institution, the role of palliative SBRT in BCLC HCC patients. So in this, radiation therapy was used as a palliative treatment in 35 patients with mainly VP4, 75% of the patient. Lymph node metastasis was there in 60%, distant metastasis in 50%, with the ECOG performance of 1 or 2 in 83%, LV grade 2 or 3 in 86% of the patients. So the patients was not fit for any other mode of local regional therapy and was considered for radiation therapy. So post-treatment, there was improvement in the quality of life. We can say this because there was improvement in the pain, abdominal discomfort, loss of appetite, and weakness in about 80 to 85% of the patients. Here, the Kaplan-Meier curve for the overall survival, with a mean overall survival of 9 months, and local control was 80% and 1 year. There are a few cases. So in this case 1, we have a large tumor, elderly male, 10 centimeter tumor in segment 6 and 7 with VP4 tumor thrombosis. Can be easily seen on this MRI picture. And we have given a radiation dose of 40 gray in 6 fraction to the tumor as well as the PVTT. Patient has got a very high PIPCA of 66,000. Further, there was a complete response on the follow-up at 1 year, 2 years, and even after 3 years, patient is doing well. Although the patient was kept on sorafenib tablet post-radiation therapy. Second case, infiltrating HCC, large tumor in segment 5, 7, 8, and 5, with tumor thrombosis, VP4 extending up to the confines of the splenic vein. And further, the patient has received radiation therapy. To preserve the remaining liver of the patient, we have to give a very high dose to the core of the tumor, that is about 40 gray, whereas the periphery of the tumor has received about 35 gray in 5 fraction, and the portal vein has received 30 gray in 5 fraction. Further, after a year, the patient is doing well, and clinically there was no disease. Case 3, large tumor, left lobe, with the portal vein tumor thrombosis, VP4, and there was contralateral portal vein involvement as well. He is an elderly male of 75 years with VP4. So we have treated the vein tumor and the portal vein tumor thrombosis as well. And even after 2 years, patient is doing well. The point is that the patient is not on either of the adjuvant therapy. Now, is there any role of SBRT in inferior vena cava tumor thrombosis? So this is another paper which is published from our institution, where the radiation SBRT is being used for IVC tumor thrombosis, and 8 patients out of 17 had the tumor thrombosis up to the right atrium. So the radiation was given up to that extent. And during the follow-up, we have a median overall survival of 9 months. Median local control is not reached. At 1 year, it was 80%, and median progression-free survival of 8 months. For a large infiltrating inoperable HCC who are not fit for other modalities as well, again, we have treated with, there are further many studies from all over the world. One of the studies is from Tata Hospital in India. So they have also found that the dose of 40 to 50 gray in 5 to 6 fractions can be easily given with a objective response rate of about 75 to 80% and progressive disease in 10%. And again, in this group also, some form of systemic therapy in the form of TKI was given. As compared to the patients with PVTT, here the 1 year overall survival is more than 50%, because in this group of patients, the PVTT was up to VP1 only. So another case that we have treated with a large tumor of about 12 centimeter involving right lobe of the liver, segment 4, 5, 6, 7, 8 with BP1 tumor thrombosis. Further, the patient has received radiation therapy up to 35 gray, 37.5 gray to the core of the tumor and 30 gray to the periphery. And here's the volumes on the anterior, posterior, and on the coronal and the transverse plane. And then the patient was followed up with immunotherapy in nivolumab-based immunotherapy, and there is complete response at 1 year. Further, radiation therapy can be used as a sequential therapy with locoregional therapies. So these are the meta-analysis where TACE with radiation therapy was compared with TACE alone, and in another meta-analysis, SBRT was compared with SBRT plus TACE. So in both the meta-analysis, they have suggested that there was increase in overall survival and local control after a combination of therapies. So as we all know, as per the guidelines, BCLC-C, the treatment is systemic therapy. So in this trial, they have tried the locoregional therapy, that is TACE versus SBRT, TACE plus SBRT versus sorafenib in BCLC-C group of patients. So what they have found, they concluded that the locoregional therapy, even in BCLC-C, is far better than systemic therapy. And there's an improvement in the median PFS, time to progression, and overall survival. So this is for sure that combination radiation therapy with TACE is a treatment which is usually done in all the patient and is of the choice. So what should be the sequence of radiation with TACE in this randomized controlled trial, which is published in Hepatology International last year only? They have tried radiation therapy followed by TACE versus TACE followed by radiation therapy. And in this trial, they have found that the median overall survival and the median progression-free survival was better in the group who has received radiation therapy first, followed by TACE. This is another case that we have treated large HCC segment 5, 8, segment 4. So he has received 3 sessions of TACE. After 3 sessions of TACE, there was decrease in the arterial enhancement and size of the lesion as well. Further, he received radiation therapy to the lesion, and this is a follow-up scan of at 6 months and at 1.5 year. So it is suggesting of complete response. Although because of the necrotic cavity, the size is reducing with time, but the patient is in complete response. Now, SBRT with TKI, as per the RTOG 1112 trial paper from Laura Dawson et al. Published in JCO 23. So again, in this study, they have showed that the combination of radiation therapy with sorafenib or any TKI, if it is of reference and it should be used in the patients, and it resulted in an improvement in median overall survival and median progression-free survival. So as we all know that instead of sorafenib, now lenvatinib is being used because of the newer trials. So in this propensity score matching analysis, SBRT was compared with SBRT and lenvatinib. And again, this trial has shown by the Yang et al. That there is an improvement in the overall survival to the tune of 69% as compared to 49%. In 1 year progression-free survival, 34% versus 9%. So the combination of SBRT with TKI has worked. So in this trial, they have used all the 3, that is TACE, SBRT, and sorafenib. And it's the randomized trial, and they have compared the TACE with radiation with sorafenib versus sorafenib alone. And it has showed that the triplet therapy has a better median overall survival, and the median overall survival is increased by 3 times in this group of patients. Although there was no difference in the median PFS, but the PFS at 1 year is slightly better in the triplet arm. Now, SBRT with immunotherapy, usually there are 2 types of tumors, the cold tumors and the hot tumors. Hot tumors are the tumors where the tumor infiltrating lymphocyte is more than 60% as compared to a cold tumor where the stromal TILs are less than 10%. So with radiation therapy, we can convert the cold tumors and the hot tumors by increasing the recruitment of the T cells. So with radiation therapy, there is more of the antigen release, immunological cell death, resulting in radiation-induced antigen-presenting cell maturation and antigen presentation to the dendritic cell, which then leads to increase in the T cell, and there is T cell recruitment and infiltration of the tumor in the tumor, infiltration of the T cell in the tumor. But due to the immunomodulatory effect, there is sometimes increase in the PD-1 expression and the Treg cells also. So here we use, that is why the immune checkpoints have a role. So with immune checkpoints like inhibitor, like PD-1 inhibitor or PD-L1 inhibitor, we can block this pathway, and in turn leads to there is a synergistic effect between the SBRT and immune checkpoint blockers. In this propensity score matching analysis, TASE was compared with radiation therapy with immune checkpoint inhibitors. In this study, nivolumab was used as a ICI, and what they have found that at the disease control rate at 6 months was 81% versus 38%. And with these two Kaplan-Meier curves, it has been found that the overall survival and the progression-free survival was far better in the combination arm of SBRT with ICI as compared to TASE alone. So this is another patient whom we have treated, and he has received the immunotherapy as well. This is a large tumor with the inferior vena cava tumor thrombosis, supradiaphragmatic. So he has received radiation therapy to the entire tumor and the inferior vena cava tumor thrombosis as well. And then he was capped on immunotherapy with atezolizumab and bevacizumab. So this is a scan which is done at 18 months, suggestive of complete response at the primary site as well as recanalization of the inferior vena cava. Now SBRT for oligometastatic disease. So as per the consensus, there is no consensus for the definition, but it's an umbrella term which is used for oligorecurrent disease or oligopersistent and oligoprogressive disease. Usually we consider less than 5 lesions. Point is, if we can treat the lesions with a curative intent, it is oligometastatic disease, but if we cannot treat, then it is a metastatic advanced disease. Here are the few studies which has been published where oligometastatic disease, the lung metastasis, all lymph node mets and bone mets have been treated along with the liver lesion in 2 of the studies, and in all the studies they have showed when systemic therapy is combined with local therapy, there's an increase in the overall survival, progression-free survival, as well as the quality of life, because these are the metastatic patients. Like in bone metastasis, they must be having some pain. So with radiation therapy, one can improve the quality of life as well. Again, a few cases that we have treated: large tumor in the segment 5 and 6 with lymph node metastasis at the presentation, treated with radiation therapy to both the sites simultaneously, and then followed with nivolumab. So this is a scan done at post 2 years and is suggestive of complete response at the primary site and the metastatic site as well. Another large HCC of the left lobe of the liver along with segment 8 with lung nodules at the presentation. So we have treated the liver disease along with the lung disease simultaneously in one go, and the scan done at 6 months is suggestive of complete response at both the primary and the metastatic site. Another patient with large HCC and bony metastasis, lumbar vertebra, sternal vertebra, and the spinal vertebra process of the thoracic region was treated simultaneously for the bony liver lesion and the bony metastasis in the sternum and the spine transverse process. During the 1-year follow-up, there was complete response at the primary site, the metastatic sites which were treated by SBRT, but yes, patient has developed more metastasis at the other sites, and was taken for re-radiation to other different sites. Some uncommon scenario, ruptured HCC. So with ruptured HCC, we generally tend to say that there's no life after in such patients. So in this patient, the TACE was, we have treated the patient with TACE single session. There was decrease in the size of the tumor. Further radiation therapy was given, and the patient was doing well even after 6 months post radiation therapy, decreasing the enhancing component and the size of the rupture. For HCC, recurrent HCC post LDLT has undergone multiple lines of TKI. The disease is progressive, have undergone multiple TACE and microwave procedures for the liver recurrence as well. So we have given radiation therapy to the portal node, multiple liver lesions, and subcarinal nodes simultaneously in one go. So these are the color washes. The dose was given up to a dose of 30 gray in 5 fractions. And these are the follow-up scans, suggestive of no arterial enhancing lesion in the subsequent scans. So is there any role of re-radiation as well? When we have treated the patient, whether we can retreat the patient. So yes, we can retreat, and it is a feasible option without excessive liver toxicity in this paper as well. But it depends on the size of the tumor, the doses which was prescribed earlier, and the time interval in between the two. So emerging techniques are proton therapy and MRI-based SBRT. Proton therapy is based on the Bragg's peaks, means the dose deposited in the medium increases with the distance traveled. So maximum dose is deposited at the end of the path. So that is why it is based on this phenomena. And here are the color washes for BMAT, that is photon therapy versus the proton therapy. In proton therapy, due to the Bragg's peak, there is minimum spillage and lesser toxicity to the liver. Whereas in BMAT, there is more spillage and increased chances of toxicity. In this trial, where proton was compared with photon, so it can be seen that even with proton therapy, they can give a higher doses up to a BD of 110 gray with less chances of RILD, that is radiation-induced liver disease, and better overall survival. MRI-guided SBRT is another new emerging technique. It helps in real-time visualization of the anatomy during the radiation therapy, online adaptive radiation therapy, re-radiation with lesser adverse effects. So way forward, this is a pilot study which is done from our institution. Here we have taken the patient sample before radiation therapy and at the end of radiation therapy. What we have found that there is increase in the PD-1 expression in the patients who are viral-related HCC as compared to the NASH-related HCC. So although it's a pilot study, but we can say that because of the increase in PD-1 expression, so these patients should be preferred for immunotherapy as well, and they might respond to immunotherapy in future. Another, it's an unpublished data from ILBS, it's a pilot study where cell-free DNA as a real-time in monitoring has been used as a to predict the clinical response post-SBRT in HCC patient. So in this patient, we have taken the sample pre-SBRT and post-SBRT. So in all the patients, the cell-free DNA has reduced post-radiation therapy except in one. So when we have seen the data retrospectively, it was found that in this patient, there was early local recurrence as well. So we can find with the cell-free DNA, we can find the cell tumor DNA as well, and further telomerase and exosomes mutation analysis can be done. So it's an unpublished work, and we'll be doing more work on regarding it. So to conclude, SBRT is a safe and feasible option for advanced HCC, and therefore should be considered as a multidisciplinary fashion for the patient presenting with advanced HCC. It not only improves the quality of life, but also results in good local control and overall survival with acceptable toxicity. Thank you. So the SBRT is a ray of hope for all the advanced HCC patients.
Thank you, Dr. Sharma. About talk the radiation therapy in SCC management with or without tumor PVT. And thank you. Nice presentation and interesting case. And I have one question. How the term SBRT and immune check blocker? SBRT first, next immune check blocker, or immune check blocker first and next SBRT, which is better?
The SBRT followed by immune checkpoint inhibitor is a better option, because with SBRT we can convert the cold tumors into hot tumors, and with SBRT early local control is there. So early local control in turns lead to translate into increase in overall survival and better responses.
Okay, and another question. You showed the better response of oligometastatic tumor, and technical point. Before you perform the SBRT, did you mark the tumor or not? For example, Lipiodol or something. Lipiodol marking, did you before performing SBRT?
Please pardon?
Before you perform SBRT, did you mark the main tumor by Lipiodol injection into the tumor or not?
No, sir. In many of the patients, radiation therapy is given post TACE, means those patients who are not eligible for TACE at the presentation, or they have recurred after TACE and not eligible for further locoregional therapy, we have considered those patients with SBRT. And because we have 4D CT scan in our department with symmetry, so in the CBCT, we can easily visualize the tumor on board imaging. So that is why lipidol is not required.
Okay.
Professor Kanda, may
Professor,
I speak?
nice to meet you.
Thank you. Excellent talk, Professor Sharma. You pointed out that especially the combination therapy of SBRT and chemoembolization, also sorafenib and checkpoint inhibitors. The results better than alone treatment. I would like to ask, of course, another locoregional therapy, transarterial radioembolization. It seems that not so logical, but is there any study, combination therapy of TAR and SBRT?
Yes, sir. So radiation therapy, TAR has been used in along with SBRT, but in that combination, TAR is being used for the primary tumor of the liver, whereas SBRT was used mainly for the portal vein tumor thrombosis.
The second small question, how about the dose of the radiation? This is the fixed dose, or it depends on the tumor size or some other laboratory test?
So it depends on the remaining liver volume and the tumor itself. So the smaller tumors can be treated up to a dose of 50 grain 3 fractions. If the tumor is very large, as in our cases, or there is involvement of the PVTT, sometimes we have to reduce the dose so as to prevent the doses to the remaining liver. So our priority is the remaining liver as well. We have to maintain a dose of less than 15 gray to the remaining liver. So that is why in many of my cases, I have shown a red hot spot in the tumor, whereas the periphery is being covered with a blue color wash. That means the bulk of the tumor is receiving more dose to a dose of 35 to 37 or 40 grain pipe fraction, as well, whereas the portal vein or the periphery of the tumor is receiving less dose, so to reduce the radiation-induced liver injury.
Thank you very much. I congratulate ILBS is becoming a very, very wonderful hepatology center in the world.
Thank you, Professor Dogmeji. Is there any question from audience? One question from audience. How does SBRT to the liver influence distant metastasis or lymph node metastasis?
So when there is liver disease along with the lymph node metastasis, it's better to treat both the lesion in one go, and one can easily treat. So what we have seen in our cases, that when the metastatic site as well as the primary site is being treated simultaneously, the patient has a better overall survival and local control.
May I ask a question?
Yes.
Dr. Abbas. Yes, Dr. Dokmichi asked about TR, trans-arterial radioembolization. And in Pakistan, we perform TR for those patients who have the portal vein thrombosis, tumor thrombosis. So are there any studies from your center or from elsewhere which approach in patients who have the portal vein thrombosis, tumor thrombosis, would be better, whether this would be SBRT or TAR?
So there is no head-on comparison between the TAR and SBRT. And in the trial, in the study which is published from Medanta Group, New Delhi, they have showed the combination of two has a better survival, and as such there is no trial. So we prefer PVTT for treating the PVTT. SBRT is a better option. But if there's large tumor, then that can be taken care by TAR or SBRT alone, or the combination of TACE or SBRT. Means TAR procedure is also not available in all the centers. So we have to customize our treatment according to the availability, sources availability in the center.
Okay. Thank you. Thank you, Dr. Sharma. Nice talk. We will move to next talk. Is there Professor Laroya? Is there?
That's right, sir. Thank you. Yes, I'm here.
Okay. I introduce Professor Shalini Laroya. She graduated from Calicut Medical College with distinction and completed her post-graduation from the prestigious Dewan Changed Agarwal Imaging and Research Center, New Delhi. She was awarded the National Gold Medal for standing first in the All India National Board examination in radiology. She did her senior residency training from Postgraduate Institute of Medical Education and Research, Chandigarh, and GB Pant Hospital, affiliated to Maura Azad Medical College, New Delhi. Due to her keen interest in abdominal and hepatobiliary imaging, she joined as faculty at ILBS and has done specialized work in transplant and hepatobiliary imaging in the past 7 years. She was the core person involved in establishing the Department of Radiodiagnosis at ILBS with installation of dual energy 46-slice CT scanner, 3 Tesla MRI, and ultrasound machines with contrast ultrasound facility, portable ultrasound, digital X-ray, and angiography suits. She has initiated and is involved in ongoing research work in the fields of MR elastography, multispectral CT, and contrast sonography in the Department of Radiology at ILBS. She is an accomplished orator and has presented various papers at national and international podiums. She has excellent publication in the field of abdominal imaging, where her core interest lies. She has more than 30 profiled papers and scientific exhibit to her credit. Today's her talk.
Thank you, sir. Thank you. That's a very nice and long introduction. But I'm just thankful to be here. I'm really grateful to your entire APASL team and Dr. Sareen and your entire panel for having me here. I think I'll just move on with the work that we do on an everyday basis. And this session was actually meant to be a little interactive. So if our panelists are interested, I'll be happy to see their responses on the chat box. And if not, then of course I'll be sharing the cases and their solutions. So we are going to discuss today not the classical but the atypical manifestations of HCC on imaging. And I will be including CT, MRI, and ultrasound in my discussion of cases. So we all know that the classical LIRAD talks about non-REM arterial phase enhancement, non-peripheral washout, and an enhancing capsule to define what is an HCC. For example, this is the same patient with CT and an MRI. This is an arterial portal venous phase and a hepatic venous phase CT. Here we have AFE, or the arterial phase enhancement, followed by central washout and a small capsule forming at the end of the hepatic venous phase. On the MR, this is seen better because of the inherent soft tissue resolution of the modality. Look at the enhancement here, central washout, and here is a beautiful capsule around this lesion. And this is a 1-hour delayed hepatobiliary phase. Since we use gadolinium bosta, which is available in India, we really don't have Primo West or EO West, which the South Asian countries like Japan and Korea have. We don't have that in India yet, but what we have is gadolinium bosta, and that gives us a 1-hour delayed phase, a beautiful washout of this lesion. Now, what I have described here forms the main criteria of a LIRAD lesion. Now, what we're going to talk about today is, if the lesion doesn't show these characteristics, for example, it doesn't show all of these but has interval growth. Let's not get there, but let's talk.
Now we are sharing your slide from our secretariat. So would you please instruct us? Next slide, something. Now it's starting at the starting slide now. So
slide did not moving.
This is the first slide.
Yes, true. Yeah, still first slide.
Yes. So, are you okay with this? Should I carry on?
Yes, ma'am. Yeah.
Okay, thank you. All right. So then the next.
Yes.
How come I'm not able to change this?
Okay. Yes.
All right. All right. So let's look at this. Let's look at this scan. Now we have a lesion here. It doesn't show the classical enhancement that you had in the previous slide. There is indeterminate washout, and there is some sort of a hypodense nodule on a cirrhotic liver. in this patient. Now, would we call this a classical HCC? We will not be able to because of the Lyrath criteria that it doesn't show clear-cut assay, it doesn't have a capsule, and it shows some sort of an indeterminate washout. What happens is that in nodules less than 2 centimeters, usually the classical appearance of arterial enhancement only happens in 66% cases. And also in pathologically well-differentiated HCCs, assay is only seen in almost half of the cases, which means we can miss 50 to 40% of cases if they do not show classical arterial phase enhancement. For example, in moderately or poorly differentiated HCCs, by the time the HCC is poorly differentiated and has a bad prognosis, we do get the classical features. But the group that we want to look at is this, where we want to pick up these smaller lesions so that we can treat them adequately and send them for intervention or for surgery. Now, this is like in biopsy with a small, well-differentiated hepatocarcinoma, hepatocellular carcinoma. Now, let's move on to our first case. This is a 50-year-old male with a chronic Hep B on follow-up, and he comes to us with the CT findings here. Would anybody want to put up their responses to what they think this could be? I think the slides, are the slides moving now? I think the slides are moving now.
Yes, yes.
Yes, so okay, so anybody has any responses, can you put in the chat box here? It'll be nice for me to see your responses. Okay, anyway, now, so till we get responses, I'm going to move on. So this is just a little bit of diffuse arterial enhancement. And here we don't really see any lesion. There is no washout. And I really don't see any lesion with a capsular enhancement or any sort of a washout area or abnormal area here. What I actually see is the red herring is a soft tissue lesion in the area of the portal vein, which is nothing but a thrombus in the portal vein. Now, these kind of lesions are nothing but, we followed up these patients on CUS, which is contrast enhanced ultrasound, but these kind of lesions are nothing but serotomimetic lesions where you see them like a focal confluent fibrosis, but they're not really focal confluent fibrosis. They are serotomimetic SCCs or infiltrative SCC patterns. And this is what we had in this patient as well. There was this area which is arterial enhancing. I'm going to show you the contrast ultrasound images for this patient. Look at the echogenic area on ultrasound. It's the same corresponding area on CT. We give contrast to this patient on ultrasound, and there is a light bulb enhancement of the lesion. That's the area on the B mode study. And here is the entire capsule and everything enhancing in the lesion. And here is a central washout on a little delayed phase of this contrast ultrasound. So this lesion, we labeled it as an infiltrative SCC, and it was later biopsied and found to be a serotomimetic or an infiltrative kind of an SCC. So there are two entities. There is an infiltrative pattern and there is a serotomimetic pattern. They both look a little different. I'm going to show you both. This is an infiltrative SCC where we did see arterial enhancement. In a serotomimetic SCC, we will not even see this sort of an enhancement in the parenchyma of the liver. So the AFP for this patient
excuse me, slide is okay. Now, case 50-year male with chronic Hep B on follow-up slide. Now.
No, I'm on the contrast study slide, but I'm moving the slides here. Are they not showing you there?
You just see the slide we're showing from the Zoom system. So maybe you're saying.
Stop sharing? It says it's sharing live.
We are sharing a slide from our side. So would you please see?
So when I'm moving the slide, are you on the infiltrative SCC slide?
We are moving on behalf of you. So would you please instruct
us?
Okay,
I go back.
Yes.
Is this the one that is on? Hep B, 50-year-old male with chronic Hep B. Is that the one that is on? No.
We're showing that the case 50 years, something like that.
But I am moving the slide here. Okay. So I think you should stop sharing and let me share my slide from here. I think you shared the slides from your end. Please stop that. I will share the slides from my side.
Okay. So we stop it. Please.
Yes. I'm going to share my slides now.
Oh, yeah, please. Thank you.
Can you see a slide which says infiltrative SCC?
Yes, but please make it wider, like slideshow.
Yes, yes, but it's showing, right? It's showing, the slide is showing, right?
Yes. Yeah. And could you put a slideshow?
Yeah, that's what I'm trying to do.
Thank you. Yes.
Yes. Now you can see?
Yeah.
So it says 50-year-old male with Hep B, right?
Yes,
Yes,
yes.
ma'am.
Yes. I'm going to move it to the next slide.
Thank you so much.
Can you see the something at the bottom? And this is the next slide. Is that visible now, the ultrasound?
Yes, we can see.
Yes,
Yes.
ma'am.
Thank
Okay,
you.
I think that's fine now. Yes. Thank you for stopping me right there. Okay, so this is the contrast enhanced ultrasound for this patient, and here is an echogenic area. We give contrast here, there is enhancement. This is the corresponding B mode image, and here is the enhancement on the arterial phase, followed by the so-called portal venous phase and the delayed phase, where there is a lot of central washout. So this patient was infiltrative SCC, was later found to have an AFP of 5,500 units. Should I keep going? Can you hear me? Okay, and this is a diffuse heterogeneous lesion. So I was saying something about a serotomimetic SCC, and this is what a serotomimetic SCC would look like. Another patient with a 57-year-old male patient, cirrhosis like SCC. We really don't see any mass lesion here. When we give contrast, there is no arterial enhancement. All we see is a thread and streak appearance of the portal vein, which has tumor thrombus in it, and it is showing enhancement on arterial phase. This is just a cystic area of the liver superior to this lesion. It has no value with this tumor. All it's showing is a large cystic area, but caudal to that is the section, and there is no mass lesion here. On the portal venous phase and the delayed phase, I really don't see a mass lesion here. The clue to in such cases is only an arterial phase enhancing thrombus in the portal vein, which on the portal vein, which on the later phases shows up as a thrombus in the portal venous and hepatic venous phase. No defined mass. So this has to be not missed by the radiologist, because this is a cirrhosis like HCC, which means it has infiltrated into the liver parenchyma, but it is not showing up as a mass. Such lesions only present as a diffusely nodular liver, not a dominant mass, and they have better histological differentiation, low proliferative tumor activity, and a lack of metastasis, which means they have a better prognosis than the other lesions. Let's look at this lesion. Look at this mass here. There is an exophytic component of the mass lesion. There is arterial phase enhancement, and then there is washout in this area. But what I'm truly trying to show you in this lesion is the pattern of this lesion here, which is a mosaic pattern. This mosaic pattern is known as mosaic because of the infiltrating fat within such mass lesions. Here is a larger area of fat involvement, and this is the capsule with the washout of the main part of the tumor with a central part of fat within it. Now, this is a very, very important component that one has to be very aware of. Microvesicular stenosis is much more common than seeing these large areas of fat. 20% of SCCs are bound to have fat within them, and they can range from in the range of 1 to 1.5 centimeter. The incidence of smaller tumors is about 35%. And this has been labeled as an ancillary finding in the LIRAD table. Look at this lesion. Like I just said, 1 to 1.5 centimeters. This lesion is about 2.5 centimeters. There is no obvious arterial enhancement in this lesion. Look at the portal venous phase. There is no capsule, no washout. There is no apparent area of a tumor-like lesion. Why? Because it is being masked by the fat within the tumor. So this patient had NASH. This patient had fat within the liver itself. So if a patient has NASH, and we know that this patient is a known case of NASH, we have to be always very careful of such lesions which do not give a typical arterial enhancement and may appear to be non-enhancing. That's because of the fat within it, which does not allow the arterial enhancement to be overt or obvious when we are seeing the scans. Such lesions have to be looked at by MR itself and have to be dealt with very suspiciously and would usually warrant a biopsy. We did give it a LIRAS 3, but we said this is more likely to be an SCC. On ultrasound, such lesions will also mimic hemangiomas or fat-like lipomas, and they will be echogenic vis-a-vis an HCC, which may appear heterogeneous on ultrasound otherwise. Fatty HCCs have less well-developed internal angioarchitecture and pathological series, and that is the reason why the vascularity is not very well seen in such lesions. Moving on to an MR. MR shows a large lesion here. This is an in and a post phase. This is chemical shift imaging. And an area inside this, if you note this is not a nodule in nodule appearance. What we see here is actually a fatty area within this mass lesion. This area is hyperintense. This is also iso to hyperintense, but this area is hypo on fat suppression image. That means only this part is fatty and the rest of the lesion is the soft tissue mass. When we give contrast, this part of the area enhances, which is arterial enhancement. This area doesn't, and it remains like an area of washout, or it may appear like a small area of necrosis, but it truly isn't necrosis. It is just the fatty area within it, and this is the area of washout, followed by this large tumor here with a faint capsule forming around it. This also is a fatty HCC, and here I've marked the areas for you. Now we've seen such similar lesions. What do you think would this lesion be? Any takers for the diagnosis? Do I have something on the chat? Okay. I'm not getting anything on the chat. I'm not getting anything on the chat. Anybody would like to share and say what they're seeing on the chat? All right. So since I'm not getting any responses, so now this lesion looked like a, looked like exactly like the previous one that we saw. Here is the one, but actually this lesion is another lesion. This showed multiple smaller lesion and a larger lesion here. We had to biopsy this lesion to rule out. The only giveaway key was that this liver was non-cirrhotic. There was no history of cirrhosis. There was no history of Hep B or any other liver disease. And hence, these large lesions with arterial enhancement, a similar capsule-like appearance, and washout was nothing. We gave it out as a hypervascular metastasis or multifocal HCC, but it was actually neuroendocrine mets. So the biopsy showed that this was suggestive of a metastatic neuroendocrine tumor, which is a surprise for us. But truly, no surprise, because neuroendocrine tumors also behave as hypervascular lesions in the liver. Moving on to the next case. Okay, so this is something that the previous speaker has already talked about, and this is a liver which is cirrhotic. But what is the soft tissue here? The soft tissue here is subdiaphragmatic. It's above the liver and below the diaphragm, and we see a lot of soft tissue. But what we need to note is that it is enhancing on the arterial phase. So there is some enhancement of the soft tissue part here. It is not just hemorrhage that we would think it could be, or a ruptured abscess. And here we see hemoperitoneum, because this was blood within the subdiaphragmatic area or the perihepatic space. And look at this, we've already described it. What exactly could this be? Because it has the enucleation sign, and enucleation means that apart from a large tumor, there appears to be tumor tissue coming out of it, which is the enucleation sign, and it is enclosed by the tumor. Hence, this was a ruptured HCC into the subdiaphragmatic and the perihepatic space. But what gives away is the arterial enhancement, supply of vascularity from the arterial structures, and this is the area of washout with hemoperitoneum within it. So large tumor size, like we've already seen in the previous talk, large tumor size, increased intertumoral neovascularity, contour protrusion, portal vein thrombosis, trauma, and rarely TACE could also lead to tumor rupture, which is usually seen in up to 1.5% of cases. Now, this lesion, we labeled it as a visceral lava migrans because it appeared totally non-arterial enhancing, had the classical appearance of conglomerated lesions clustered together, and also giving some sort of enhancement with small areas of liquefaction within it. They also seem to be central in the segment 5, and this is what we thought was a visceral lava migrans. But it actually turned out to be, to our surprise, an HCC, which is not really enhancing. We call it an inflammatory pseudo tumor. Any guesses on what this lesion could be? I'm not getting anything on the chart. So when I don't get anything on the chart, I believe that there is nobody has anything to say. So here, so this is a lesion with hypodensity. I hope the slides are projecting, right? Is there someone on the meeting?
Hello.
Yes, am I connected?
Yeah, you're connected. Slides are moving. Go ahead,
Okay.
please.
Fine. I thought there is no response from any of the chats, so fine. I'm just increasing the size. Okay. So this was any guesses on what this could be? So this is a very rare tumor. Here we had a large cystic area with areas of enhancement within the lesion, and this is a soft tissue component within the lesion, and multiple arterial enhancing lesions studded in the liver. Like we saw, this appears in the last talk. We just saw that this appears to be, a post-TACE or a post-tear lesion with areas of liquefaction. But this was a de novo HCC, and this was actually a cystic degeneration of a large HCC lesion, and the other lesions were all arterially enhancing. They show washout in the later phases with capsule formation. This is a completely untreated HCC with central liquefaction and necrosis. So such lesions should not be mistaken or misidentified for post-treated lesions or for cystic metastasis from other such adenocarcinomas or aggressive malignant tumors. Usually biliary cystadenomas, metastasis, and cholangiocarcinomas can appear with the same appearance, and like I said, should not be mistaken always for this. So the only end goal is biopsy. This is a very interesting case. This is a CT and an MR of the same patient just for elucidation. Here is a CT, a plain scan. If you're wondering what this is a stent, a CVD stent within the bile duct. Here is the arterial enhancement of a large lesion. What is to be noted is that the lesion is encasing the bile duct here. Look at the encasing soft tissue here and how it has progressed. This is the capsule and the washout within the lesion. Arterial enhancement later, and here is the large washed out tumor. On the MR, this is a plain scan. This is diffusion where the mass lesion is apparently seen. Look at the beautiful comet tail-like appearance where the tumor is extending within the bile duct, and here is the bile duct encasing it. This is the enhancement of the lesion, and this is a corneal reconstruction where you can see the capsule and the lesion is invaded. This part of the duct is missing. This black part is the duct, and this part of the duct is missing. The tumor is involved, the entire duct, as well as the right portal vein. So this is the SCC, which is invading an extrahepatic extension into the bile duct, along with being the cause of obstructive jaundice. Now, this again is a very, very rare presentation of SCC, and it's usually seen in Asian population more than the Western population as I searched the literature. Here is the cut section of the resected liver from this patient when underwent a extended right hepatectomy, and this is the tumor invading the bile duct here and the rounded encasement of the mass lesion. Let's look another MR of another atypical SCC. Why I've rounded off this area, that you can see this speck of a bright spot out here and another dark spot out here. So this is an in and out phase or a chemical shift imaging. If we see a bright phase on a T1 weighted in phase, that means there is hemorrhage or mineral deposition. This is likely to be hemorrhage if this is a mass lesion. And here is the fat suppression sequence, so which means that there is a suppression on a fat suppression sequence, means this is intratumoral fat. So there is intratumoral fat, and also on the contrast study, we see areas of biliary dilatation. So these are peripheral bile ducts. This is a solitary HCC lesion, which seems to be extending. Look at the lesion here. This is washed out in the portal venous phase, and on the delayed phases, it is extended into the porta. And if you look at the corneal reconstruction, you can see how a solitary tumor here has now invaded the bile duct. How this is different from the previous tumor is that this is a de novo solitary lesion inside the liver and has then infiltrated into the peripheral bile duct. Whereas that lesion that we saw on the previous slide was evolving around the bile duct. So there is a little difference in the two, but the manifestation is the same. It will present as biliary obstruction. So this was internal fat as well as hemorrhage into the lesion and extension into the segmental duct. A very, very rare presentation. Another rare presentation here is a patient presenting to us with multiple skeletal deposits and metastasis. There is one lytic lesion in the vertebra, here in the ribs, and in the large mass lesion in the scapula. All are intensely enhancing on the arterial phase. Look at the enhancement here. And this is the key lesion, the primary lesion in the liver, and a large adrenal deposit as well. So it is rare for an HCT to be presenting as lytic metastasis of the skeleton, which shows similar enhancement, hypervascular pattern, and the adrenal lesion as well. Like here, I'm showing you skeletal and adrenal mets are less percentages of involvement by HCT. In such lesions, we can use the spectral CT beautifully. Now that itself is a large topic, but what I'm going to deal with in spectral CT is a spectral CT only gives you differentiation of material composition, whether iodine has moved into a lesion or not, and it can quantify the iodine within it. When we quantify the iodine, we can say for sure that there is enhancement within this lesion or not. When we see likely or not very intensely enhancing lesions, all we need to do is quantify the iodine within them and compare it to the parenchyma around it. So what I've seen here, the red dot is within the mass, which is HCT, and here is the blue dot, which is the liver. When I look at lower KAVs, it's difficult to make out the difference between the two. As I increase my KAV, which is the kilo electron volts, to about 75 to 80 as a window, I can start to see the difference between the two lesions, and hence spectral CT helps me in distinguishing these two lesions by using spectral CT images and my graph. It also helps me quantify the iodine on these iodine density images, where I see these lesions better than what I would see here as a delineated mark. So if I'm unsure of something like this, I would move on to a spectral CT. Looking at another atypical presentation, venous involvement, we can see the IVC here loaded with the tumor thrombus. That's the IVC in the axial section. This is the culprit lesion. And here is a large mass in the upper part of the segment 8 as well as segment 5. It has adrenal mets as well on both sides and multiple lung deposits, all coming from the same lesion. This lesion has distinctly metastasized into various components and has vast extension and infiltration. All these manifestations are a little rare, and CT would be the ideal modality for such a situation because you want to see distant metastasis. Now, a very intriguing case, a 57-year-old lady. She just complained of heaviness and pain. She had no previous liver disease, came to us for an MRI as a study, and this was literally an incidental finding. I see here a large mass lesion in the left upper quadrant, and it is compressing the stomach. We have given some oral contrast to see, and the stomach was compressed. All I see here is a large mass lesion in the left upper quadrant. And here are the other T2 weighted images to delineate the lesion better. And there is this large lesion taking over the entire left upper and mid abdomen and seems to have an infiltrating plane with the left lobe of the liver, from which it is literally hanging out like a huge fruit from a tree. So this is a large mass lesion. We had it biopsied right away, and we gave a differential of a mesenchymal or a gastrointestinal tumor or a subdiaphragmatic leiomyoma because this looked like a large mesenchymal tumor. And our biopsy was really surprising. This was found to be a fibrolaminar HCC arising from the left lobe of the liver, completely exophytic in its component with a large central scar. So very, very atypical presentation of that. This was a 51-year-old male. We diagnosed him as an SCC on imaging because he had a classical large right lobe involvement and lots of arterial enhancement. That's the tumoral, representation, so that when you do a TACE, we know exactly which arteries are supplying the tumor. So I would always advise to get a nice CT angio done so that we can see how the tumor distribution from the vessels is. And here is a large central necrotic scar. It's not a characteristic scar. It's probably a scar because the tumor has outgrown its supply. And here we have a large area of necrosis, playing the right anterior portal vein and the right posterior portal vein. And here it's even lifting up the diaphragm on the right side. And this is how we depict this entire tumor. On biopsy, this is found to be on the gross pathology, it was resected. And here it is found to be a large fibrolamellar carcinoma. So word on the fibrolamellar carcinoma, it has been perceived as a variant of conventional HCC. It's a very small proportion, hardly 15% of all HCC, seen to arise in a distinct group, either younger 20 to 35, no gender predilection, but both our cases were of 51 to 52-year-old, male and female both. There is literally no association with previous liver disease or any geographical distribution. These are usually solitary, as it was in both our cases. And AFP, which is usually a giveaway in other HCCs, is normally in the normal range. Management also is unique to this tumor. It is aggressive surgical management, and transplant is one of the rare indications where it is indicated in such large tumors in cases like this. Moving on to another case, a 65-year-old gentleman, cirrhotic for 3 years, of HPV, AFP, CEA, CA19, every tumor marker is normal, comes to us for a CT scan to look at what is happening. And here is a tumor where we see a large cranial component which has mild enhancement on the outside, a caudal component as we come down, which was minimal arterial enhancement, no significant enhancement, but here there is some arterial enhancement. The caudal portion has no arterial enhancement. The cranial portion has bile duct thickening and bile duct involvement with dilatation. Here is the caudal portion where there is only minimal involvement. Caudal portion shows portal vein thrombosis, and here is a delayed phase where we see the thrombus better. Now, what is happening? We're getting mixed signals from this lesion. It is neither behaving completely like an HCC nor like a cholangiocarcinoma, because it has arterial enhancement not seen in cholangiocarcinomas, and it has progressive enhancement without washout not seen in HCC. So obviously, if there is a mixed signal, it has to be a mixed tumor, which is what it was. It was a combined hepatocellular carcinoma and intraductal cholangiocarcinoma. It was biopsied, and this is the coronal section of the same. Look at the biliary involvement. It has biliary dilatation as well as arterial enhancement. Multiple nodes are usually seen more in cholangiocarcinoma, progressive enhancement later with infiltration of the bile duct and a large biliary ductal dilatation as well. Itself, patient had a left hepatectomy and followed by chemotherapy after histopath diagnosis. And 2 years later, the patient had multiple deposits in the lung. This is the biopsy specimen from the same patient. Now, sometimes benign-looking lesions like these come to us in the emergency room. This patient has come from outside, referred to ILBS as a liver abscess with a pigtail catheter inside the lesion. Here we have arterial enhancement. Why I'm showing you this case is obviously because it's not a liver abscess and it's in our HCC series. And the red herring here is that there is no real enhancement outside of this lesion in the parenchyma. There is a lot of arterial enhancement. These appear like soft tissue septations and not like just classical rounded, well-defined enhancement. Makes me very suspicious. And I asked for a biopsy from the periphery of this lesion. This lesion is also probably ruptured and there is pleural effusion in this patient. And lo and behold, it is found to be an HCC on biopsy, and it's just a necrotic HCC which is mimicking a liver abscess. Another patient here, these are the CT images, 4 of them, and these are the similar MR images of the same. When we see a large solitary lesion, characteristic enhancement, plain arterial phase enhancement with capsule formation, and here is a large area of washout. Similar thing on MR, this is the plain T1, T2, diffusion distinct, it is intensely restricted, and here we have enhancement with washout and a capsule. Not all such lesions and all that glitters is not gold always. So we asked for an HCC. The core biopsy done outside was suggestive of HCC, but there was no extrahepatic disease. And we all also thought that this is an HCC. This is a very teaching case. This patient underwent a resection. This is a tumor resected from the liver. And here are the slides. The pathological specimen showed that there were some neuroendocrine components to this. After that, we asked him for a daughter knock PET scan, and here is the main carcinoid or the main tumor, and these were the metastases, which means that large metastasis was the tumor in the liver, and this is the residual left liver seen on the daughter knock PET scan. So this taught us a very important lesson. Whenever we are evaluating HCCs or solitary lesions in the liver, especially in a non-cirrhotic lesion such as this one must always look at the entire abdomen and the chest as well to look for primaries with solitary metastasis. And this is what that lesion was. Another case, 65-year-old gentleman with all tumor markers normal on HPV follow-up. And here we see this large lesion here in the caudate lobe. Looks like an enhancing tumor. There is a beautiful washout and it appears to have a capsule as well. Multiple nodes in the lung, I thought these are metastatic nodes, and here there are multiple nodes in the abdomen as well. What do we see in the coronal reconstruction? This tumor seems to have infiltrated the IVC. Let's move on to the next section. There is a reconstruction that we made for this arterial lesion. Supply from the aorta, just like the IVC derives its supply from the aorta, the same thing the lesion is deriving its arterial supply from the aorta. There is a cleavage plane between the IVC and the liver, and the tumor seems to have a central area within the IVC. So what appeared to be actually a liver lesion is truly an extrahepatic IVC lesion. It's an IVC leiomyosarcoma, which is just infiltrating or having a cleavage plane with the liver. This was it's a spindle cell sarcoma, which is similar variant to a leiomyosarcoma. And we must always be wary of extrahepatic lesions infiltrating into the liver. I'm really running short on time, so I'm going to run through these cases. This was again a last red herring case. Lesion looks very aggressive. These are just plain T2 images. This is the T1 with areas of hemorrhage. When we do a contrast study, it is so classically like an SCC, lots of arterial enhancement, areas of washout, capsule formation, and we feel, oh, we have an SCC on our hands. But this is a young 21-year-old boy, and he had on biopsy was found to be a telangiectatic adenoma. So what I'll say is that not all hypervascular lesions have to be thought of SCC, and not all hypovascular lesions should be dismissed as non-SCC. So we must have always a discriminatory approach and going for a biopsy whenever we need to, and make as best the diagnosis on imaging as possible. With that, I would like to thank you for your patience.
Thank you, Professor Timer. Many interesting cases. Fibrolamellar carcinoma is very interesting.
Yes, it is truly. So
Yeah.
2 cases, and then we did see 1 or 2 more, but it is a very dicey lesion.
Is there any question, Professor
May I
Dogmeji?
talk?
Yes,
Yes.
please.
Thank you very much. Excellent talk, and also very informative and detailed information. Also, your cases are really excellent. As you know, hemangioma in the liver is seen very common, and radiological appearance of the hemangioma is very informative. And sometimes, in some cases, we cannot distinguish that is the hemangioma or hepatocellular carcinoma. Can you give us some specific clues for the differentiation of these 2 type of solid nodules?
Right. So that is a very good question. Actually, there are many hypovascular lesions with which SCC can be mistaken. Hemangioma is one of them. But our real problem arises when it's not a classical hemangioma. So a classical hemangioma will never be a problem for a good radiologist who's used to looking at hepatobiliary imaging. But a sclerosed hemangioma is a challenge for anyone. If the hemangioma is sclerosed in the middle, it is not going to fill in or opacify completely. And that appearance may look like a washout or an incompletely filled SCC. And in those cases, we will have to go by the Lyrath criteria of growth in the interval phase. So we look at all the major criteria of Lyrath, which says arterial enhancement, capsule formation, washout, and interval growth. If all the 4 criteria are met, then of course we have to call it an SCC. But if all the 4 criteria are not met, and especially in an MR, if you can look at a hemangioma, I mean, usually the garden variety will not be a problem for anybody. Any good radiologist will be able to see it. But a sclerosed hemangioma is definitely an issue. In those cases, I would recommend a contrast-enhanced ultrasound or an MR. Even a CT would be fine, but these 2 modalities are better and more sensitive. So sclerosed hemangiomas are the only challenge. A regular hemangioma will never be a challenge.
Thank you.
Professor Abbas?
Yeah, excellent presentation and good collection of cases. I just want to know, because most of your patients underwent MRI to discriminate what type of lesion is this. So what type of contrast are you using? Because sometimes we get fear with elevated creatinine that patient may have nephrogenic systemic fibrosis with gadolinium. So there are other contrasts like gadoxinate or Primovist that we are using here sometimes. So I just want to know your experience of you choosing the contrast while giving MRI.
Right. That's a very good question, sir. So like I mentioned in my talk, so there are two things. The contrast available in India is gadolinium Bopta, which is not Primovist. It is a different contrast. The only difference between Primovist and Bopta is that Bopta excretes the liver contrast into the biliary duct after about 60 minutes, whereas Primovist excretes, the hepatocytes excrete Primovist within 20 minutes. So that is a bigger, that's the main issue. And the uptake of Bopta is about 5 to 6%, whereas of Eovist or Primovist is about 50% as well by the hepatocytes. Now, having said that, both contrasts are equally good if you have a good MR machine. Like we have shown you, on MR, we're usually able to pick up enhancements very well. And if not on MR, you could always use a very good CT, and both CT and MR together should give you the same solution. I would not say that Primovist is better than Bopta. I would only say that it is faster than Bopta, but at the cost of the price of the contrast. So Bopta is literally 1/5 the cost of Primovist or Eovist. And I think looking at the cost factor, I would say that Bopta is equally good. Secondly, you talked about the renal issues. Now, nephrogenic systemic fibrosis is a very, very rare entity. In fact, I searched up the literature because we have a lot of patients who have kidney diseases along with the liver problems. I know you get the same amount of patients with kidney disease as well. MR is a very, very safe contrast. Whether you use Primovist, Eovist, Bopta, or any other contrast, they're all very safe contrasts. Nephrogenic systemic fibrosis is very, very rare compared to iodinated contrast from the CT. And if you have a well-hydrated patient, which we always do, we always ensure that the patient is well hydrated. It should not be a problem to take up any patient for a CT or an MR. So I think that is the main issue. Creatinine is a very, very, it's a very gross marker. It's not a very good marker. It's actually the GFR that has to be looked at. But with MR, we rarely have had any patient. In fact, the entire world literature, there is more worry about it than it's an actual reality. It's really a very, very rare phenomenon.
Thanks, Professor Salini. I think now, so people are listening so long, it is quite a cost 2 hours in webinar, but there is good attendance also, but still it is interactive. So I think Professor Kanda, we hope we have done for the day. So we'll going to close this session, and as we have planned every month, second Tuesday is going to be the ALCAP. So we'll meet again in the next month. So thank you all experts, and thank you Professor Kanda to be graceful in short notice. I'm highly obliged, and all our APASL executive members. And I thank you all on behalf of Professor Sarin, and we are going to close this session. Thank you.
Professor Kanda, thank you very much.
It's a great pleasure. It's my pleasure. Thank you.
Also, this is
Have a good night.
Pleasure. Okay.
Thank
Hi,
you,
Professor Sarin,
Sarin.
how are you?
Very nice to see everyone, and thank you, Professor Kanda. Thank you very much, and thank you, Kadir, and everyone and all the speakers. It's very nice, very grateful. Thank you.
Have a good day.
Have a good day. Bye-bye.
Bye-bye. Bye.